All right. So what do these patients look like? So let me give you a little introduction to that. So here's an example of a relatively recent cohort that was published, just to kind of give you a rough idea of what these patients look like. Now, this cohort, these patients are a little bit older, but you can see that they present with all sorts of symptoms. And we're going to dive a little bit more into that in the next lecture when we talk about some specific cases and how those patients presented. Remember, it's an older population in these malignant gliomas, so you have to think about their comorbidities when you're thinking about their therapies. These tumors, again, are occurring in all sorts of locations. In this patient population, a large number were located in eloquent areas of the brain. We'll talk more about that in the next lecture as well. And in this patient population, you can see gross total resections were really only 63%. So that's actually a reasonable number. We wish we could get gross total resections on all of our patients, but the fact is there's a lot that we cannot for lots of reasons. There's different definitions of that, but I think probably the most common definition of a gross total resection is going to be resection of that enhancing part of that tumor that you see on the MRI. And how much of that represents gross total? Well, I think most people would argue 95% of that enhancing part of that tumor probably would represent a gross total resection. These patients get other adjuvant therapies. In this cohort, most were able to get through that standard of care of radiotherapy temozolomide. And then many patients move on afterwards to other chemotherapies. And this is a very short list of other chemotherapies that are used out there. Of course, none of these represent standard of care. So this is all beyond that standard of care at 6 months. So I pulled up this example because it illustrates those prognostic factors I mentioned. So we clearly know that age is an important prognostic factor. So in this survival curve, younger folks obviously do a lot better than the older folks. We know that those who have a higher KPS have a better survival curve than those who have, the lower KPS. And again, 70 is about where we really start to see the difference in how well these patients do when they go through these aggressive therapies. Lots of data out there shows that when we do gross total resections, they have better survival than subtotal resection. And then for patients who get beyond that standard of care, beyond 6 months survival, and they are able to move on to something else, they tend to do better. We don't know what that something else is, so we're not certain, or we haven't established any specific other chemotherapy out there that's beneficial, but if they get moved on to something, they tend to do better than those who are not getting any additional chemotherapy. And we know that when we have populations where we might have to modify care, for example, the elderly, that if they will do better if we can get them through some of those standard of care options. So this is just an example of an older population where the survival is better if we can get them through all those standard therapies. Should you do surgery if unable to get gross total resection? So I've been emphasizing this gross total resection. And we have lots of data that shows it should be sort of the standard. So here's a good meta-analysis showing lots of studies, and in all these studies, gross total resection favors improved survival. Even in older, more frail patients, if we can get gross total resections, that favors survival. But as I also emphasized, it's unrealistic to get that in all of our patients. And so we have to think about how to handle subtotal resections. And there is certainly lots of favorable data out there that supports benefit from subtotal resection. So then you have to ask yourself, well, what's a reasonable subtotal resection? We haven't really answered that question, I don't think, but I would argue that if your post-operative MRI shows that you've gotten maybe 70% of that tumor, that's probably a beneficial subtotal resection. Of course, more is better. If your MRI shows that you're maybe at 50%, well, you probably should be thinking about trying to get that patient back into surgery to see if you can do a little bit better job. You have to remember that these are very aggressive tumors, and when you operate on them, they react. So they easily hemorrhage. They can have malignant levels of edema right after surgery. So if you leave a sizable amount of tumor, you might be dealing with those sorts of complications that can be very traumatic for your patients. But if you, for example, get that 70% subtotal resection and you get your patient on to the rest of the standard of care, then that clearly is going to be beneficial for.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.